everybody, and welcome to DocTalk. I'm Dr. Erin Knopf, and I am joined today by Dr. Carolyn Coker-Ross. And I'm just so excited to have you here because in our short time knowing each other, I feel I have learned eons of information and important words of wisdom that I hold close to my heart now in all the work I do. So thank you for
Thank
agreeing
you.
to be here. For those of you that don't know Dr. Ross, where have you been? First of all. Second of all, Dr. Ross is an MD, MPH, and certified eating disorder specialist, an African American author, speaker, and expert in the treatment of eating disorders, trauma, and addiction. She had an amazing TED Talk, which I recommend everyone listen to, Historical and Intergenerational Trauma, that was aired in January 2020, I believe. So you got in before the pandemic. She's also the co-founder of the Institute of Anti-Racism and Equity, a consulting group that offers trainings to organizations on diversity and equity in the workplace. Yes, obviously I'm reading this because I don't want to miss a detail. And she is also one of the authors and editors on a new book, Anti-Blackness and the Stories of Authentic Allies, Lived Experiences in the Fight Against Institutionalized Racism. Shout out to Norman Kim. So excited to read this book. So excited to just hear from you. So thank you again for being here.
Thank you for having me. It's exciting.
So we are talking about something uncomfortable, and I said before, but it's good to be uncomfortable around this. We were talking about bias in eating disorder treatment and care. And what is your hot take in this moment of the current environment for eating disorder care and what's getting in the way based off of biases?
Yeah, I think it's no different for eating disorders than for addictions that, people of color, Black, Brown, Indigenous people don't have as much access to eating disorder treatment. They are less likely to get diagnosed, less likely to complete treatment or even get into a treatment facility. And a lot of that has to do with cost, it has to do with people being uninsured and so on. And I think in general, there's a lack of inclusivity, particularly in the eating disorder world, which really is based and focused on thin white women of middle or upper class. And no matter how much we go around the country and talk about that people of all, races, gender identities, etc., abilities and so on can have an eating disorder, that remains in people's mind as the guiding light of eating disorders. So I think that's an issue that's really still around. And I think for people of color, particularly Black women, have higher rates of the binging disorders, but they still have equal amounts of anorexia, for example. And again, we're not seeing them show up for treatment. Part of that is on our end that our culture has some denial as to whether or not Black women or men could have an eating disorder. So we can own that part, but the systemic issue is much, much larger and harder to address, actually.
It is so daunting, I think, to some degree. Part of why individuals may not be seeking care is because of their mistreatment by the systems beforehand, either directly or indirectly in communities. But I think even more so, you bring up a great point that there is still so much reliance on data that was skewed, had selection bias.
Bias. Yeah.
Yeah, just bias as a whole that misinformed generations of clinicians at this point, not just physicians, but dietitians, therapists, etc. I mean, it is wild when I still have to help a pediatrician, for example, know how to screen and know how to ask and who to ask and really ask everybody. There's still a block of, but I don't need to ask this person. It's weird that they can't shift even with new information presented. What do you think is
Takes 17 years to change anything in medicine. 17 years.
17? I did hear 20, so that makes sense. It rounds up.
Close, yeah.
Okay, so what year then are we expecting to see some radical change here at this point? What's the
Yeah,
math?
the year 3000, I think.
3,000.
I think that's an optimistic number, particularly if you look at all of the issues around size.
Mm.
We've gone through the health at every size movement and, tried to educate physicians that you can be healthy no matter what your size is. There's been a big outcry about using, the O word and how that has really been a biased way of addressing these issues. And even the question of, is there an issue? Um, One of my favorite books oh, I won't be able to remember the name right now, was a researcher in Minnesota who wrote something about the diet lab. Anyway, she studied size issues and health, and there really is no correlation between size and health until you get to the very, very big extremes. As a matter of fact, even on the other end of the spectrum, being thin is a health risk. If you're sedentary, you smoke, you have unhealthy eating habits, and so on. So, size is not something we should be measuring and following and browbeating
Pathologizing.
and browbeating people with, So that's an example of how the medical profession has been stuck in this. And oh my goodness, when the GLP-1s like Ozempic came out, it was like a feeding frenzy in my profession, in the medical profession. It's like, whoa, suddenly we can control people's weight. This is going to be so great. And yeah, there are changes in, some of the numbers that, whether it be the metabolic numbers like blood sugar and blood pressure and so on. But we know that it takes very small incremental change in those numbers to vastly improve health. You don't have to lose, 100 pounds or be thin to be healthy.
That would be very unhealthy for you to lose such a dramatic amount so quickly.
Yeah.
And you bring up a great point that there is this kind of, I don't know what the word I'm looking for, but this exaggeration influence between the war on size and how that translates to BIPOC health, because we know size diversity is a thing, and people who are not white, Caucasian, European descent have different body sizes, proportions that will translate differently when quote unquote BMIs are brought into the conversation.
Yeah.
And so it almost creates this immediate judgment that someone in a perfectly healthy full body might receive when they go to their doctor's office. And that person also isn't getting asked the question, do you do anything to manipulate your size, to restrict your size? What is your relationship with your body and food? No one gets asked those questions when the physician or clinician in front of them is only seeing size as an issue.
Yeah, and assuming that that means everything. I think the other part that I'm kind of on a bandwagon about has to do with trauma, because we know that BIPOC people, children, adolescents, and adults have higher rates of trauma. Some of it is from discrimination, microaggressions, which people experience on a day-to-day basis. Some of it is trauma that we tracked in the ACE study and beyond. But at any rate, we aren't really screening little kids for trauma, and we're not screening teenagers for trauma. I mean, I think in some areas in California there is universal screening, but it's very, very unlikely that you'll go to your pediatrician and be given the ACE test. And that is so critical. When we talk about if you could substitute size for anything in the world that has to do with health, it would be trauma, because trauma increases the risk for chronic disease, for depression, anxiety, substance use disorders, etc. And yet that fact, which has been verified over 25 years of research, is not being used, and it's often not being screened for in treatment centers either.
I think it's uncomfortable for people. I remember being a med student and hearing, if you don't ask about sexuality and sexual activity, you might be missing something from the health history of this individual. And it was something you had to get over of like, ooh, we're going to talk about something that's normally very private, but let's talk about it. I feel like trauma is one of those things that even trained adults, knowing the data, feel uncomfortable. Maybe this would be a good study. Like, do you feel equipped and prepared to talk about trauma with your patients? Maybe, and this is me absolutely giving a devil's advocate benefit of the doubt moment, but I do think ultimately it comes down to a lack of awareness or consideration, truly, of how much that is at play in someone's life.
Yeah. The thing is, you don't have to do anything. Like, you don't have to treat trauma. All you have to do is have some therapists on speed dial who do treat trauma. And then you say, hey, I see you have all this trauma. It may be affecting your eating. It may be affecting your drug or alcohol use. Let me refer you to a specialist. And that's not hard to do.
No, it's
So, I mean, when I do my intakes for people with depression, anxiety, eating disorders, addictions, anything. The number one question that I always include is, can you tell me if you've had any trauma? And you do have to get a little bit into it. Like, oh, has there been divorce in the family? Does anyone in your family have substance use disorders? Have you ever experienced any kind of abuse? Or give them the ACE quiz. It's pretty easy. But the bottom line is, I normally just say to them, give me the overviews, whatever you feel comfortable with. And then I go and record that. And then I try to educate them. Well, there are studies that show that your risk for ADHD is much higher because of your trauma, for example. So it might be useful to explore getting some treatment for this trauma and then refer them. I don't know. That doesn't seem that hard to me.
I would agree, but again, I like getting into these, again, psychiatrists here. That's what I'm going to do. And I even say, hey, trauma is, there's big T's, there's little T's, but it's all relative to someone's life. It really matters what impacted you. What did you experience? What left you feeling the feeling of neglect, isolation, unloved, or fear? Like, did you actually fear for your life? Those are things that matter, and we need to talk about it.
I'd like to just say, as you know, we've had all of this backlash now against DEI and anti-racism and so on, which is fine. I mean, it's not
It's
fine.
not fine.
I don't say it's fine. I'm just like so overwhelmed by it all. But one of the things I think is really important is that I think all of us, no matter whether you're white, you're Jewish, you're Muslim, no matter what your religion is, your gender identity, sexuality, all of those things, all of us want to feel like we can be authentically ourselves. And to me, the biggest effect of trauma is making people believe that they are unable, or it's not okay, or it's not safe to be authentically themselves. And I think when you look at things from that umbrella, it makes a lot of sense that diversity and inclusiveness and belonging are important, because all of those things help people to feel like they can be safe to be authentically themselves. And I think that's really important. You have patients, young Black women with eating disorders. And I had one recently say to me that she just didn't feel like she could be herself. She was too much, or too loud, or too smart, or too fill in the blank. And I'm sure you've had patients who are not people of color say exactly the same thing. Now, where the need for DEI comes in, or anti-racism comes in, is that we have to recognize that there are groups among us who have long generational histories of pretty significant trauma, historical trauma like the Holocaust. You know, if you're a descendant of enslaved people, that's huge. And so those things, that intergenerational component that I talked about in my TEDx talk, is something we have to take into consideration. But on every level, all of us want to be able to be ourselves. And 63, 65, or some people say even 70% of people in the US and in most Western countries have at least one adverse child experience. Trauma is all around us, and wherever you go, you take your trauma with you. So that's what's going to show up when you go into treatment. And if you're in a treatment facility that doesn't address that, your recovery is not going to be very solid.
Yeah. It's heavy, but
Okay.
it's good that
Talking.
no, not at all. This is exactly what I think everyone needs to hear. And I think there's still so much more to really recognize. If our goal in providing care or treatment is to help someone return to a life connected with values and with recovery as the goalpost, there has to be a component there where you do connect that person with their own human nature, their own humanity. It's not just about the psychobioeducation around how these maladaptive coping strategies impact the brain, blah, blah, blah. But it's more of, okay, but who are you without this? And we do have to know full backgrounds. That's why it's not just asking about parent history or grandparent history for shits and giggles. It's really shapes an understanding of what this human inherited from an epigenetic perspective and what could be addressed, what can be named. So I'm just still sitting with what you were saying. And frankly, I'm at a bit of a loss for words. So you put me in a humbling position at the moment. I guess what I wonder, since you brought up anti-racism, I find it so fascinating, actually, this visceral reaction that people sometimes have to that term. And I wonder what your take is on that
Yeah.
and what you do about that.
Well, I think most people, when they hear the word racism, think, the Ku Klux Klan. They think of, I mean, seriously,
Yeah, no, it's real.
they're
It's the most
really,
extreme version.
yeah, and they're really worried that you're calling them a racist, and they don't
Yeah.
think they're racist. But when you look at it, everybody who is a natural American has been swimming in the sea of racism since back in the 1600s when they brought the first enslaved people over to America. So it would be almost impossible for any of us not to have some biases, and those biases often are anti against certain types of people. We also have biases against certain religions. We have biases against LGBTQ. I mean, we're seeing that play out with trans people, which is horrifying. But these biases are the source of what we call racism. Now, America was different than any other country that had enslaved people in that the enslaved people this was chattel slavery. And that means that human beings said they could own other human beings. And they built an entire kind of framework to justify that. And the real reason that they wanted to own other human beings is because of free labor. It's all about the money in America. You know that. It's greed, greed, greed. And that's what's happening. That's what we're seeing play out again. If you can vilify certain people and you can keep them from moving up, you think you're going to have more, but it doesn't really work that way. And eventually that will come out. But when I hear people react to anti racism or DEI, I have to really stop and think that we can't deny our history. They say if you deny history,
Bound to
you're
repeat it.
going to bound to repeat it. And we've seen that in so many different cultures and other societies. So I think it's important to just recognize these things happened. It wasn't your fault. You weren't even alive then. However, if you try to pretend like they didn't happen, that's going to be a problem. Because there's a whole spate of us here who have ancestors who it happened to. So we're not going to be forgetting that anytime soon. And
Definitely
I
not.
think where we go from here has to do with just accepting. We're not saying you are a racist. We're saying we all have racial biases because we grew up in America. And so if we become more aware of those biases, we'll have a better chance of treating people fairly.
Yeah. And I think for anyone listening, if this is new to you, ask yourself, what are stereotypes that either you hear about in jokes, in common conversations? What is your own behavior, perhaps, when you run into a certain individual? If you're passing a Black man on the street, for example, that's a number one thing so many white women would say, oh, I hold my purse closer to me. Okay. That is an example of an embedded implicit
Very,
bias and
exactly.
stereotype that was taught to you, whether directly or indirectly, but it exists. And the first thing you do is just recognize, oh, I know that stereotype. And guess what? Then you can have power, like you're saying, to understand how that can affect and impact other people and what to do about it.
Yeah.
Truly.
And I think also have to acknowledge that many white people in America feel as if they're being treated unfairly and that Black and brown people are being given or have been started to be being given certain opportunities that they weren't. And I can understand how that feels because in 2020, after the murder of George Floyd, anti racism work really expanded because it needed to. You can't watch someone's grown son being murdered on television and not feel like things need to change. But I don't think that means that you're going to lose something and we're going to have something. It just means that we need to acknowledge what's not working in our country and work to fix that. So it's a hard concept for people to understand, isn't it?
Well, I think this is just my take now. I see so much of that scarcity mindset showing up. Everyone, especially when we are stressed, the first thing we do is try to protect and get small or
Hold
hold
on to
tight.
everything that we have. Yeah.
Correct. And yeah, to your point, this was not a pie that was getting cut up differently where people had smaller pieces. It's simply recognizing this is still happening. This is still wrong. We need to do stuff about it. Because when we talk about biases, it'd be one thing if the opinion was there on its own, but it leads to mistreatment and discrimination and people being stripped of their dignity and humanity. Those are principles no one should tolerate.
Yeah.
So, as much as it might be uncomfortable to admit we live in a culture that has always had discrimination with preferred races over others, preferred religions, preferred sexes. I mean, the patriarchy is still a thing. It's real. It's happening. It's here. I actually just had a patient today who's a young teenage girl, and she was minimizing how she responds to unwanted touches from male peers. And she doesn't want to rock the boat. She doesn't want to make waves. And I said, girl,
Yeah.
no, this is your body. You do not have to please a man. You do not need to please this boy. You are not too loud or too much if you stand your ground. I mean, that is the patriarchy creating mistreatment of young girls. And that is a historically inherited way of being forever. So, guess what, everybody? When we talk about bias and anti racism, it's not just about the race, it's all of these levels of systemic oppression and discrimination that we are calling
Yeah, and
into view.
actually, the DEI work has benefited white females more than it's benefited any other group, in
That's
terms of,
interesting. I actually didn't
yeah,
know that.
yeah, in terms of people getting into corporate America. The glass ceiling is still there, and we've never
Right.
still haven't had a female president. But women,
I
particularly white women, have had many more opportunities since the civil rights movement went through. The second group that we don't think about are disabled. Those with disabilities have been benefited by the civil rights movement. So it's kind of like, I don't know who said this, and maybe something was in the Bible, but if you bring along the least of us, it impacts the most of us. When we focus only on, like we are now, people who are billionaires and think they have the answers to all our problems and they're hurting the least of us, it drags down the whole country. You can see the whole mood of our country has been deflated. And I think that we really need to get back to recognizing that there's plenty of space for everybody under the umbrella and everybody wants to live their lives authentically.
I think liberty is something everyone wants and freedoms. And just because you disagree with how someone lives their life, and who they choose to marry, doesn't mean that it takes away from your happiness. Let them be, leave them alone. But now we're getting into like a bigger issue of just stop hating each other.
And why can't we all just get along?
Why can't we just get along? I love that you brought up, though, abilities versus disabilities, because I do think that is another area of bias that shows up really obviously in ED care, especially when you're looking at higher levels of care. There's so much overlap and comorbidity between autoimmune issues, chronic fatigue, chronic pain issues, and eating disorders. I don't think we have even enough data to really create numbers for it, is my impression. But anecdotally, I could say, I don't know, 25% of my patients meet that intersectionality. And part of why they don't go to care is because they can't receive enough accommodations to rest and to be comfortable. So I wonder if you have thoughts on that.
Yeah, well, ableism and civil rights have been integrally intertwined. And actually, disabilities was one way in which enslaved people were kept down. They're just not able, they're disabled. So we have to take care of them. But I think when we look at eating disorder treatment and ableism, it's really important for, again, not violate the person's civil rights. The right to adequate treatment, the right to have their needs met should all be part of what makes eating disorder treatment effective. And I know that some of these things are expensive, but I remember in the old days when I started, we didn't even have chairs that could accommodate people of size. So that was a huge thing when suddenly people started thinking about getting bigger chairs in their waiting room. Like, wow, okay. And I think we have to think of it like that. That's why I say this isn't just about race. If you look at all of the biases that we have, that many of us have, and even BIPOC people who have incorporated, internalized racism, it's important to address those biases. That's why I like your premise of, virtual care because someone can sit in their own home where they're comfortable. They don't have to come into an office that doesn't meet their needs.
Yeah, totally. No, that was definitely part of our goal of bringing the expert clinicians that you would have access to at higher levels of care. Now they are meeting you in your home. Yeah,
Yeah.
100%. Thank you for naming that. And thank you. I am curious with your insights and knowledge, wisdom, what strategies or frameworks have you seen be most effective in creating culturally responsive and anti racist eating disorder care? Are there concrete tools or models that you think have the most success?
I think it's hard to find those models in eating disorder care, but maybe I've missed them because I'm not in a treatment center right now. But certainly in addiction care, I've seen the model that happens at Friendly House in Los Angeles. We started doing consulting work with them on diversity, equity, inclusion, belonging. Oh my goodness, it's been 3.5 years ago, and have for most of the last 3.5 years been embedded with them. And it's been
Cool.
yeah, it's really cool because you really get to see two things. One is how it works if someone is really committed to it. And the second thing is that spillover effect that I was telling you about. So I think maybe at year 1.5 or 2, we actually went to Los Angeles. I mean, it's easy for me. I'm only a drive up the road, but my colleagues had to come from the East Coast. But we just sat with the staff and said, well, what's it been like? What are you guys seeing? What have you noticed? And what honestly really surprised me, here we were mainly focusing on traditional DEI, just education, raising awareness, having tough conversations, letting people tell their stories, and then helping them navigate the issues that came up. And everyone from the chief executive officer down to the techs said, I feel I have a seat at the table now. And they were not black techs. They were white women, and one was British, and all of and I always call her the child of the colonizers. So she's fabulous. Uh,
That's
um,
hilarious.
I think she would laugh at that. But the techs, the admission staff, the marketing people all said, I feel like I'm being listened to. I feel like I'm being heard. I feel like I can give my opinion now about any number of issues. And we didn't really train them to do that. It is that spillover effect when we're talking about inclusion, and then everyone starts to feel included. They start to feel like they belong and that they're important to the organization. And they've been able to also change their board of directors. They've also been able to increase the number of patients from the LGBTQ plus community, as well as from different BIPOC communities in Los Angeles. And so they've really lived the model. Have they had bumps in the road? Absolutely. But I have to say, it shows you what commitment does. And that's the biggest problem that I see in the eating disorder world, because our bias is skinny white women, middle class, upper class. I talked to someone who's in the field, and her, like, why aren't you getting more diverse staff? Why aren't you getting a more diverse patient population? Well, we can't take Medi-Cal. Well, you know what? I think the number is $3 trillion in the BIPOC community coming up that's available for things like this. So not everybody who is in that community is someone who's poor. Absolutely not. We have lawyers, we have doctors, and I think again that's a bias,
That's a bias. It's an assumption. Yeah.
an
That they
assumption.
must be destitute.
Yeah, and
Yeah.
and even if you are taking Medi-Cal patients, there are ways to offset that by having patients who are paying insurance.
Yeah.
There are different ways you can work it if you want. If you're committed. If you're committed, you can find a way to do it. And I think that's where we're lacking in the eating disorder world. I think people they're very comfortable just having young white females coming into their centers and paying the cash or paying the insurance. And why should
Well,
we?
I think what I noticed was I do think that's right at the higher seats, but not the boots on the ground. The boots on the ground want to do the work a lot, a lot. And I love the trickle down spillover the fact that you named. I think that's so profound. Again, this is about humans connecting with humans and being interconnected to do good work.
Yeah.
And it does matter
And you can see
that
that the
everyone has a voice.
patients are more engaged when the staff is more engaged. The
Totally.
economics work better when you have more diversity because there's more creativity and so on. But if you look at the upper ranks, what you see is no diversity. You look at some of
Totally.
the big companies that own treatment centers, there's really no diversity there.
Yeah. On a funny note, I just started watching The Residents. Have you seen this on Netflix
Oh,
yet?
that was so good. I love
So
that.
funny. I literally, the very first episode, y'all, she's just like, another white dude, another white dude. Like, what is this? It's hilarious, but baby steps. Thank you so much for your work. Thank you for your commitment and dedication. I hope you're not losing steam, your own
Yeah,
hope with
not yet.
what's happening with the current state of the world. Just know that you are on the right side of history. You are absolutely on the right side of
I
history. And
hope I live to see the other side.
I mean, I'm going to do everything I can to make that a reality. But everyone, this was Doc Talk. Thank you again, Dr. Ross, for joining. I'm Dr.
Thank
Knopf. We will
you.
see you next time.